Now we have next talk by Dr. FERRONE. I think he's going to talk on a very difficult subject which we all face, and that is use of methotrexate in complicated pediatric retinal detachments.
Thank you, and good morning. Thank you to the organizers and moderators. It's my pleasure to talk to you all this morning, the stalwarts staying here on the last day of the meeting. Appreciate it. And we're going to talk about a very interesting subject, and that's using methotrexate for difficult pediatric retinal detachment cases. These are my disclosures. None of these are relevant. We're all familiar with PVR that accounts for 75% of all RD repair failures, and it's caused by freed RPE cells and fibroglial cells in interaction with growth factors and cytokines. We also are familiar with, as we just heard from Dr. Bende, that the difficulty in separating the posterior cortical vitreous in children. We all know they present late and usually have macula off detachments, unfortunately, and more than half of these patients present with grade C PVR. Methotrexate's been reported in adults, and though we're familiar with it as a chemotherapeutic agent and immunosuppressive agent for uveitis, it also has dramatic anti-proliferative abilities, interfering with the S phase of the cell proliferation cycle, and also has significant anti-inflammatory characteristics. The adult studies are numerous. The most well-known study was by Elliott in the GUARD trial, where they reported an 80% attachment rate at 39 months with a median visual acuity, which is relatively good at 2200, after a total of 10 injections, 1 during surgery and 9 post-surgery. There were smaller studies subsequently that reported between an 80 and 100% reattachment rate by Benner, Ula. These are smaller studies too. One by Roca, which is a comparative study, which was significant, and one by Hughes as well as Rajan. In pediatric populations, though, the use of methotrexate the data are lacking. I published a report about 9 months ago on JVRD, which was a single case report, which I'll touch on in this series. But the only other known reported series is of 3 patients by Al Jahad, which showed a series of 3 patients, and he had a 100% reattachment rate. He used methotrexate in the infusate, as well as at least 1 injection of 200 micrograms of methotrexate postoperatively. We did a retrospective chart review of patients under 18 years old. We used a minimum of 4 serial intravitreal methotrexate injections at the standard adult dose, which is 400 micrograms per 0.1 cc. Typically, patients received 1 methotrexate injection intraoperatively at the end of surgery, followed by 3 serial weekly injections, and then 4 additional biweekly injections for a total of at least 8 injections over 10 weeks. There was some variation in this treatment protocol due to surgeon preference or specific case requirements that extended the period of treatment. And these are the 9 patients. You can see the average age was 11. They ranged in age from 6 to 17, and most had an average of 2 prior surgeries. But the etiologies are ones we're familiar with as being very difficult to keep attached. Myopic degeneration, Stickler syndrome, cicatricial ROP with a stage 4 detachment in a 13-year-old, Blau syndrome, which is a chronic granulomatous uveitis syndrome, self-abusive behavior, large peripapillary hemangioblastoma with a dense chronic vitreous hemorrhage, and a treated large retinal blastoma with a secondary detachment. Initial vision range from count fingers to light perception. Indications for methotrexate were 7 patients had grade C PVR, 1 was a ruptured globe patient, and 2 were at high risk for PVR, and 1 of those was a ruptured globe patient. 5 out of 9 patients had a retinectomy, all had membrane peeling and silicone oil injection, and the mean and median number of injections was approximately 10, with a range of 8 to 14 methotrexate injections. 5 out of 9 of these patients received their methotrexate injections under anesthesia with a brief mask induction. With regard to the methotrexate, there were no corneal complications, and follow-up was on average about 9.5 months with a median follow-up of 10 months. All retinas remained detached following initial surgery up to 6 weeks out. There were 2 cases that didn't. 80% approximately remained detached following a single operation. 2 cases, 1 redetached at 3 months post-op and 1 redetached at 1.5 months post the initial surgery with methotrexate. 4 of 9 patients had the oil removed, and 100% were reattached at last follow-up, with the vision ranging from 20/70 to light perception. This is an example of a few of the cases. This is a 9 clock hour giant retinal tear in an 11-year-old. from Stickler syndrome and had the oil in for 3 months, and this is the appearance of the retina 3 months after oil removal, and this patient remains attached, doing well. This is a 13-year-old who had a treated retinal blastoma, which you can see there on the left, with a total retinal detachment with a break not only infratemporally but also at the base supranasally of the retinal blastoma. And they were treated with 8 methotrexate injections and silicone oil, and 6 months after surgery remain attached. This is a 9-year-old with a ruptured globe, large perilimbal laceration, total hyphema, vitreous hemorrhage, total RD, had scleral buckle, AC washout, vitrectomy, endolaser. Methotrexate was not initiated after this repair, and this is what the patient looked like 6 weeks after surgery. You can see the dramatic membranes that are present inferiorly. We started methotrexate every 1 to 2 weeks at this point, at 1.5 months after the original surgery. And 2 months after administering the methotrexate, there was a repeat injection with silicone oil removal and membrane peeling, and we continued the methotrexate after that, and this is what the patient looked like 9.5 months after the initial surgery. No membranes, no reproliferation, and vision of 20/70. This is the stage 4 ROP detachment with a chronic macula off detachment with subretinal and epiretinal membranes. Is grade C PVR, as you can see. The macula is off on the OCT on the upper right, and vision was light perception. She had 2 surgeries without methotrexate. She had recurrent proliferation, retinal foreshortening, and you can see a break at 6 o'clock, and there's also a break infratemporally. There is straightening of the infratemporal vessels consistent with a dragged retina from stage 4 ROP. She was treated with methotrexate, and after having the oil in for 6 months, had it removed, and this is what she looked like 4 months after surgery. She remains attached with no reproliferation. This is a patient with Blau syndrome, which is a chronic granulomatous panuveitis. She had surgery, 2 surgeries before presenting to us. This is what she looked like pre-op. We repaired her. She looked good at the end of surgery. 7 weeks later, this is what she presented with. She has reproliferation. She had oil in. We removed the oil after peeling his membranes. And she looked good for about 4 months until she came back with this, again with reproliferation and a new break infratemporally. And we repaired her. She looked good. And then 2.5 months later, she presented with reproliferation infratemporally. You can see around that laser on the right slide, right part of the slide, and proliferation posteriorly to see on the left part of the slide. This is the point at which we used methotrexate. She received 8 methotrexate injections, and 6 months after the surgery, she's had no reproliferation of membranes and remains attached with no distortion of the retina. So in conclusion, repeated intravitreal methotrexate injections appear to facilitate persistent retinal reattachment in children with complicated retinal detachments who otherwise would not likely remain attached after complex vitreoretinal surgery. Thank you for your attention.
Thank you very much, Dr. Philip Ferrone, for an excellent presentation and dealing with a complicated situation. I have one question for you. How much methotrexate you inject once the oil is already in there?
0.1 cc, no problem with pressure.
Okay.
Just right into the oil bubble and no issues.
Okay.
Yeah, no corneal issues, no pressure issues. We always check the pressure after the injection. And a lot of the kids you can do in the office. We tell them we're giving them a special drop, and the parents, of course, are okay with it. And the kids take it and do very well. You know, about half the patients we had to put to sleep, but you know, don't forget we're operating on some 6-year-olds there and 8-year-olds and 9-year-olds. So, but once they get into the early teenage years, they're usually very good about it in the office.
Sorry, and you said an average of 8 injections. Average of 8 injections, you said.
Yeah, on average, but some had more because what I would do is I'd use 8 injections for the initial retinal reattachment surgery, but then when I took the oil out, I would give them another series of injections, less intensively, you know, at surgery with oil removal, and then every 1 to 2 weeks for a period of about 2 to 2.5 months, so they have no reproliferation. Because, as you know, all these eyes have breakdown of the blood-ocular barrier, and they can form fibrin like that. So you just want to suppress them as much as possible, and that program has been working very well in these difficult cases.
Thank you very much, Dr. Ferrone, for being here. He has to leave. If there is any kind of a one question quickly, we can ask him.
Exit frequency is once a week. How you decided the frequency for intravitreal?
Well, that was what they used in the GUARD trial for adults. They used it weekly, And I'm personal friends with Dean Elliott, and we were talking about in kids what we thought might be ideal, a good balance. So my impression was use it at surgery, use it weekly times 3 so the kids can tolerate it, but you're still suppressing the proliferation or reproliferation, and then every other week to keep things quiet for a total of 3 months with the initial retinal detachment repair surgery. Subsequently, when I take the oil out, I do it at surgery, maybe weekly times 2, and then every other week for another 8 weeks or 6 weeks, depending on how severe the case is.
Thank you, sir.
Sure.
Thank you, Dr. Ferrone.
Thank you.
Being,
Yeah.
yeah, thanks.